Good afternoon, everybody, and welcome. As she said, I'm Lori Melliker. I'm a Senior Program Officer at the Robert Wood Johnson Foundation, and I'm a member of the leadership team for the Interdisciplinary Nursing Quality Research Initiative, or the INQRI program. As its name suggests, INQRI is a program which believes strongly in the merits of interdisciplinary collaboration, something that begins with our own leadership team. On behalf of that team, comprised of Mary Naylor, Mark Pauley, Heather Kelly, and myself, I'd like to welcome you to the fourth webinar in our series on dissemination and implementation of evidence-based practices. INQRI is a program of the Robert Wood Johnson Foundation and was launched in 2005 to generate, disseminate, and translate research to improve the quality of patient care by supporting interdisciplinary teams of scholars to address gaps in knowledge about the relationship between nursing and healthcare quality. This is an artistic rendering from our first meeting and demonstrates all the issues we hoped this program would address. From the beginning of the program, we asked researchers to be singularly focused on what is at stake for the future. What is at stake for patients? What's at stake for nurses and for healthcare teams? We wanted them always to focus on the big picture, and we're pleased to be presenting a session today with two grantees who have done just that, Michelle Ballas and Bill Burke. During this webinar series, we have the opportunity to turn our attention to INQRI's focus on dissemination and translation. In the program's final call for proposals, INQRI sought proposals focused on projects that would promote ways to implement successful evidence-based strategies and practices. The findings from the 6 projects selected in 2010 are being presented via this webinar series. Today you will learn about a nurse-led plan to manage delirium. This session is the 4th in our series. You can access the prior sessions on our website, INQRI.org, and we hope that you will and that you'll tell others about it, and that you'll also participate in the 2 final sessions in our series. The details of these sessions are on the screen now. You can register for all of these sessions on www.inqri.org, where you can also view the previous sessions. From its inception, INQRI has been a truly collaborative program. The INQRI National Advisory Committee, or we call it a NAC, is made up of experts from a variety of fields. All are committed to improving health and health care for all Americans and to ensuring that nurses, as the largest group of healthcare professionals, have a recognized central role in that effort. Brought together once a year at our annual meeting, INQRI researchers shared methods, findings, and new research questions that arose in the course of their studies. Members of the NAC joined invited guests and other grantees to provide feedback, advice, and encouragement to enhance their work. At the meetings and in other settings, these diverse and important stakeholders also helped the research teams develop key messages to effectively share what was learned. These dedicated NAC members have spent countless hours providing guidance and advice to INQRI program leaders, assisting with the grant selection process, and much more. Joining us today is one of our distinguished National Advisory Committee members. In just a moment, Allison Ryan will introduce you to Michelle Ballas and Bill Burke and their work on a nurse-led program to manage delirium. In the meantime, though, it's my honor to tell you a bit about Allison. Allison Ryan is a Senior Director for Evidence Generation and Translation at Academy Health. In this role, she directs several projects that investigate how new sources of data and expanded stakeholder engagement are helping to transform healthcare and research. Allison is the principal investigator on a PCORI contract that actively manages and facilitates collaboration among 50 pilot projects to advance the field of patient-centered outcomes research. And with support from the Commonwealth Fund and the Office of the National Coordinator, she directs efforts to assist Beacon Community Cooperative Agreement Program participants in identifying, documenting, and disseminating the lessons and results of their individual initiatives. Allison also oversees and contributes to projects that focus on building infrastructure to support quality improvement, comparative effectiveness research, and patient-centered outcomes research. Allison has expertise in health IT policy, stakeholder engagement, comparative effectiveness research, information management and governance, and community-based quality improvement, and has written and presented on a number of these topics. With over 16 years of experience in the healthcare field, she brings a range of skills to her work, including technical assistance, design and execution, collaborative network development, research design, and policy analysis. Prior to joining Academy Health, Allison was Assistant Director of Food and Health Policy at the National Consumers League. Prior to joining NCL, Allison served as a healthcare consultant to a number of private and nonprofit organizations, for which she conducted strategic assessments, market studies, and other research efforts aimed at evaluating the relative effectiveness of numerous drug, biologic, and device interventions. Allison holds a master's degree in public policy analysis from the University of Rochester. Allison, thank you for serving on INQRI's National Advisory Committee since the beginning and for leading our session today. I'll now turn the webinar over to you.
Great. Thank you so much, Lori, and thanks so much for the nice introduction. I think that's a perfect way to tell me that I probably need to shorten my bio, but I appreciate it nonetheless. So thank you all for the opportunity to be a part of this great event. I'm really excited about the work done by this research team and very much look forward to the presentation, followed by what I hope will be a really lively question and discussion period. And unbeknownst to me, prior to learning of this project, fully 2/3 of intensive care unit patients develop delirium during the course of their stay in the hospital. Delirium is associated with longer stays, billions of dollars in cost globally, and 3-fold excess mortality at 6 months. Over 1.5 of intensive care unit survivors suffer a functionally debilitating dementia-like illness, which appears to be related to delirium duration. So in short, it's a really important issue from both a health and cost perspective. The main goal of this project was to implement, analyze, and disseminate an evidence-based, nurse-led, interprofessional, multi-component program focused on improving the care and outcomes of critically ill adults. The study focused on applying a program of delirium screening, prevention, and treatment developed at Vanderbilt University and was selected as the American Association of Critical Care Nurses' first PEARL, also Practice Evidence Application Resource and Leadership, web-based tool. So now it is my distinct pleasure to pass the baton on to the members of the research team who will be presenting on this work, Drs. Michelle Ballas and Bill Burke. So thank you very much, and take it away.
Thanks, Allison. Good afternoon and greetings from the great state of Nebraska. I am Michelle Ballas, and joining me in the webinar today is Dr. Bill Burke, who is a geropsychiatrist here at the University of Nebraska Medical Center. We would like to begin by thanking the Robert Wood Johnson Foundation and all the tremendous leaders and support staff of the INQRI program. This really has been truly a wonderful experience that we believe will touch the lives of innumerable patients and their families. Oops. We would like to begin by taking the time to express our deep gratitude to all the members of our truly interdisciplinary team. If I included all the pictures of everyone involved in this project, it would probably take about 30 slides and over an hour for you to enjoy their beautiful smiling faces. But seriously, our team was truly exceptional. Our interdisciplinary research team, which was led by a nurse and a physician, included a number of different specialties. We included a pharmacist, multiple nurses with various specialties, researchers with expertise both in quantitative and qualitative methods, a program evaluator, informational technologists, some great statisticians, and physicians from multiple specialties, including trauma, anesthesiology, and internal medicine. We were also really blessed to have two of the leading ICU delirium and outcomes specialists. They're the two nice-looking men in the middle row who were able to join us as consultants on this program, and that was really fortunate as well because it gave the opportunity for our partnering institution to partner with another institution that really did have some great experience with clinical outcomes research. And Ed, hello, I see that you're on the webinar. On the bottom row is just a couple members of our the team members from our partnering institution. we really wanted to particularly acknowledge the support of the medical center's chief nursing officer, Rosanna Morris. When I approached Rosanna about the possibility of her institution participating in this INQRI study, her response was, "If it helps patients, you'll have all of the nurses' full support." And also Dave Gannon, who is the medical director at the critical care unit, who was influential in the whole process. So as Allison mentioned, the problem that we were going to attempt to address with our study was delirium. We know that delirium by far is probably the most common condition that patients that are admitted to the intensive care unit experience. It's also known as acute confusion for people that might not be too familiar with the term. It is very common. It occurs in some studies have estimated over 80% of people that are on the ventilator, and also half of those patients that are admitted to our ICUs that aren't on mechanical ventilation. In the ICU setting, by far the most common form is the hypoactive delirium, which is the more quiet, subtle form of delirium. And because that occurs, it possibly explains the reason why ICU diagnosis is often missed in the intensive care unit, with large majority of cases being under-recognized. Multiple studies conducted over the last decade in the ICU have shown that it's a really serious problem for patients and their family. In terms of what happens to them while they're in the ICU in the hospital, we know that delirium is an independent predictor of increased mortality. We know that people that become delirious in the ICU are on the ventilator longer. We also know they're at risk for being either physically or chemically restrained. They spend more days in our ICU and in the hospital. And as Allison mentioned, it's really associated with a significant burden in terms of cost to our society, with estimates of costing the United States healthcare system anywhere between $38 and $152 billion annually. One of the problems with delirium is we used to think that it just affected people while they're in the hospital. Now we know that absolutely that is not the case. Delirium has a profound effect on people even once they leave our care in the ICU setting. The mortality risk associated with delirium goes out 6 months to even a year post-discharge. We also know that people who become delirious in the hospital are at substantial risk for a decline in their functional ability. They never leave the hospital quite the same as they did when they came in. We also know older adults in particular are at increased risk of going to a nursing home or skilled nursing facility if they become confused while they're with us. In terms of delirium, it's important not just if it occurs or not occurs in our patients. Another factor we need to consider is what happened, is there association between the duration of delirium and poor outcomes. One study that was conducted by Pisani et al. Found that each day of delirium in the ICU actually increased the hazard of mortality by almost 10%, and that was far post-ICU discharge. I think one of the underappreciated effects delirium has on our patients, and probably the reason Bill got so interested in this study, was we now know that half of all of ICU survivors experience some form of cognitive impairment when they're discharged from the ICU. Recent studies indicate that the duration of delirium is an important predictor of this cognitive impairment. We also know that people that come to our ICU are at risk for a syndrome that's now known as this post-intensive care unit syndrome. So what is that? Well, post-intensive care syndrome could affect not only their patients and the families, but the conditions associated with PICS last for months to years, and possibly the life of the survivor of critical care. 10 to 50% of all ICU survivors experience problems such as post-traumatic stress disorder, depression, anxiety, problems sleeping, and the need for caregiver assistance. So we know that it is a tremendous problem, and it's really a profound and emerging public health threat. We also know that there's a number of non-modifiable risk factors for delirium. So these include things like age, severity of illness, and pre-existing cognitive impairment. These are things we can't do anything about. However, we now know that there's also numerous potentially modifiable risk factors for this syndrome. In the ICU, the three most modifiable risk factors for delirium seem to be the administration of sedative medications, mechanical ventilation, and the immobility that's associated with being in the ICU, either from physical restraints or the lines and tubes or orders for bed rest. As illustrated in the slide that you're looking at now, these modifiable risk factors are really influenced by a number of professions, including physical and respiratory therapists, pharmacists, and physicians. You'll also notice that nurses really do play a central and really essential role in not only delirium but its treatment. Any intervention directed to reducing the incidence and duration of delirium clearly has to be interprofessional and multi-component in nature because it is caused by so many different risk factors. So by the introduction, I hope I made clear to you who could potentially benefit from our work. Clearly, it most directly, hopefully, affects our patients and their families. It also has the potential to benefit healthcare workers in terms of keeping them safe from people that might become acutely confused and display disruptive behaviors. The costs are important not only to our healthcare systems, but if we can reduce the incidence and duration of the syndrome, hopefully we could avoid those 30-day hospital readmission rates and a lot of those long-term complications. The really good news is that there is a potential answer for this problem, and that potential solution is the Awakening and Breathing Coordination, Delirium Monitoring and Management, Early Exercise Mobility Bundle. So we lovingly refer to it as the ABCDE bundle. The ABCDE bundle is a multi-component, evidence-based, interprofessional strategy aimed not only at delirium but also ICU-acquired weakness. It really aims to do two things. We want to liberate and animate our patients. So by liberate, what I mean is we're trying to reduce exposure to the harmful effects of sedative medications and mechanical ventilation. By animating, we're referring to facilitating our patients to become mobilized, which really is one of the few non-pharmacologic interventions that's known to reduce delirium. There are 5 major components of the ABCDE bundle. For the sake of the non-ICU providers that might be joining us on the call, I'll try to keep it relatively simple. But the A, like I said, stands for awakening. What does awakening mean? Well, awakening means we're going to try to stop our patients' medication, their sedative drips that they're getting in the ICU at least once a day. So turning off their sedation to allow their brains to wake up at least once a day. B is breathing, which means allowing our mechanically ventilated patients the opportunity to breathe on their own once a day. C, in my experience, is really the most important part. C refers to coordination and communication. In terms of coordination, what we want to occur is the A to come before the B. We want people to have their sedative medication shut off before we shut off their ventilators and let them breathe on their own. D is delirium monitoring and effective management, and E is getting the patients up, mobilized, out of bed very early in their ICU stay, as early as possible. It also refers to things like early mobilization of our mechanically ventilated patients, so getting people that are even on the breathing machine up and walking every day. Each of the interventions in the ABCDE bundle has been shown in numerous randomized control trials published in really high-impact journals like Lancet and JAMA and all the big ones to improve a number of really important patient outcomes. At the time of our INQRI study, however, no studies looked at the effect of combining these individual components into the bundle. More importantly, there was no studies that explored the implementation part of the ABCDE bundle into everyday care. So in other words, we knew it worked in randomized control trials, but we also acknowledged that often the results of randomized control trials don't work as well in the everyday care setting. So to address this issue, we performed our study. What we aimed to do was to implement this ABCDE bundle into a medical center that did not perform routine ICU delirium screenings, and to identify the facilitators and barriers to bundle adoption. And boy, we nailed that specific aim. Number 2, we wanted to test the impact of the bundle on a number of patient outcomes, and the patient outcomes that we looked at included ventilator-free days, delirium and coma-free days, time out of bed, hospital, where they went on hospital discharge, and ICU and hospital mortality rate. We also proposed to look at a number of nursing quality outcomes, including physical restraint use, falls, pressure ulcers, the big nursing ones, and also self-extubation, so how many people, when they're awake, pull out their tubes, in particular the breathing tube, and system outcomes, so things like ICU and hospital length of stay, medication dosing and costs, and ventilator-associated pneumonia rates. Finally, we wanted to assess the extent to which the bundle implementation is effective, sustainable, and conducive to dissemination in other settings. So our study was a prospective cohort, mixed methods, very important part of that, before-after study. It was conducted at a 624-bed medical center, and the units that we included were 5 adult intensive care units, 1 step-down unit, and an oncology hematology special care unit that cared for critically ill patients that were immunocompromised. To be included in the second aim of our study, so the patient aspect of it, they had to be at least 19 years of old, which is the age of consent in our state, and admitted to either to the institution's medical or surgical critical care service. We really had very few exclusion criteria, and that was purposeful. We wanted to do that to see if it could be applied in a number of different kinds of patients. The only exclusion criteria that we had was if the patient didn't have a legally authorized representative that was available to provide consent, because our IRB deemed that we needed to get consent from both the patient and their LAR to perform this study. In terms of what we did, in terms of procedures, we had two full-time clinical research nurses, and the job of the clinical research nurses were they went around and performed daily sedation and agitation and delirium screenings. So to every patient that was in the study, they administered the RAS and the CAM-ICU, which is a well-known, valid and reliable delirium screening tool. These clinical research nurses also went around and did daily chart reviews where they recorded adherence with a number of to see if the staff was actually doing the intervention, the bundle components, and record the efficacy and safety outcomes that we were interested in. In terms of what we knew about the institution before we started the study and in the pre-implementation phase, what they looked like before the bundle was adopted into everyday care, we knew that they had some experience, like most institutions, with the awakening and the breathing trials. However, the director felt that both were performed relatively inconsistently. We also knew that they didn't have in place any kind of safety guidelines in terms of predefined criteria to say if it was safe to do an awakening trial, breathing trial, or get the patient out of bed. And they also didn't have any predefined criteria of whether or not the patient passed those interventions. There was no delirium monitoring or management in place. They did not screen for delirium. They had no pharmacologic or non-pharmacologic policies regarding how we should manage these patients. And one ICU was in the process of piloting in early mobility, but there was a very strong culture of immobility in the intensive care units. In general, patients just never got out of bed in the intensive care unit. We also knew that interprofessional rounding in the intensive care units was sporadic and really dependent on the physician practice patterns. So in terms of what the intervention looked like, post-ABCD bundle implementation, this is what was supposed to happen. So the ABCDE bundle was to be applied to every single adult ICU patient or patient requiring an ICU level of care, and it was supposed to be applied every day. So every day to every adult patient in the intensive care units. The patients, if they were eligible, would undergo those awakening trials and breathing trials. We would screen them every 2 hours for their sedation level, and we would do 8 hours of delirium screening. They would also go through a predefined daily progressive mobilization where they started slow and then walked up to mobilizing patients, walking patients out of bed. And all patients were to get this bundle on a daily basis unless a physician or another licensed prescriber wrote an order not to have the patient participate in certain components of the bundle. So in other words, we used an opt-out method, which we feel is extraordinarily important, meaning everybody gets it unless there's a specific order not to get it. It just standardizes care and makes it much more clear as to what the process is for the bundle. In terms of educational efforts before the bundle went into everyday care, we did a ton of education. We provided all members of the interprofessional ICU team the opportunity to participate in a 30-minute online computer-based ABCDE bundle training, and I'm happy to say that was very well attended by most of the disciplines. So I think approximately 300 to 400 people went through this 30-minute online ABCDE training. We also had one of the leading ICU delirium experts come out, and he did a visiting professor where he talked to all of the physicians, well, mainly the medical doctors. Some surgeons attended it. We had an 8-hour ABCDE bundle education day. So everybody, again, was welcome to come to it, but it was mainly attended by nurses. Very good turnout. Probably over 100 people spent an entire 8 hours learning about how to implement the bundle into everyday care. Again, we had another leading delirium expert, a nurse by the name of Brenda, come out, and myself. We did that 8-hour day. Practically lost my voice by the time that was over. And then we did the standard thing. So the units had posters placed up. We did the handouts that we pasted in the bathroom door, or in other words, the nurse's break room inside the restroom. We passed out pocket cards that we got from the ICU delirium study group. We bought pocket cards for the CAM and for the RAS, so that providers, we gave them to everyone, nurses, physicians, respiratory therapists, physical therapists, so that they could keep it in their pocket to see what they're supposed to be doing it every day. And we had numerous specialty-based in-services. So what did we find after implementing this into everyday care? Well, we enrolled a total of 296 patients. The good news was, in the pre and the post-implementation, all their baseline characteristics were very similar. The only significant difference was some of the patients in the post-implementation group were a little bit younger than the patients in the pre-implementation group. Otherwise, they were all pretty similar pre- and post-implementation. We were very happy to find that we had a really nice mix of patients, both medical and surgical patients. And if you look at this flow sheet, this slide, you'll actually see that our second most entered patient diagnosis would involve neurology or neurosurgical patients. So a population that you really wouldn't associate with shutting off sedation and early mobilization, but really nice mix. In terms of what we found, in terms of how often sedative drips were used, we found after the bundle was implemented into everyday care, 10% less patients received a continuously infused sedative drip, and the percentage of patients who had their sedative drip held for an awakening trial significantly increased by almost 20%. So we went from 53% awakening trials on sedative to 71%. We also found a small drop in the amount of continuously infused opioids. I don't look at that as a bad thing because we always want to keep pain forefront in our minds. We always want to ensure that our patients are comfortable and not having pain in the ICU. So there was a little bit less opioid use, but not as dramatic of a drop as the sedative use. We also found that after implementations, patients were significantly more likely to have those opioid drips shut off more days while they were in the intensive care unit. In terms of breathing results, the number of patients who had a spontaneous breathing trial at least once during their ICU stay significantly increased. So pre-implementation, they were pretty good at doing a breathing trial at least once. They went from 70%, but they went all the way up to 84%. So really good increase in the use of breathing trials. We didn't, however, find any difference in the terms of the number of days they underwent a breathing trial during their ICU stay. In terms of early mobility, the percentage of patients who were mobilized out of bed at least once increased in the post-implementation period. However, again, the number of days they spent out of bed, there was really no change in how many days they spent out of bed. And physical therapy consult use was high to begin with, and it went up a little bit post-bundle implementation. So to summarize, we saw increases in all of the use of all those individual interventions. But those increases were relatively small, although some of them were significant. So, we got much better at each individual intervention, but nowhere near 100%, the 100% goal that we had. So small incremental increase in all of the individual interventions. So what did we get by that small incremental increase in the use of those evidence-based intervention? We found some really, really encouraging results. Even though we were relatively bad at, doing this on a consistent basis, the first thing that we found was those patients that required mechanical ventilation, we saw a statistically significant increase in ventilator-free days. So what does that mean? Patients treated with the ABCDE bundle spent 3 more days alive breathing without mechanical ventilator assistance. So 3 more days that they're able to use their voice, talk to you, and express their needs, and also stay alive. So pretty good. We also found pretty dramatic results in terms of delirium, which was really the focus of our study. We found that the percentage of patients that experienced delirium anytime during their ICU stay significantly decreased. So we went from 62% of our patients in the ICU having delirium to less than half. So we went down to 48%, again, a significant drop. We also found that the percent ICU days spent delirious also significantly decreased. So we went from about half of all ICU days spent delirious to 33%. We saw it wasn't statistically significant, and that really, I think, has to do with the number of days patients stay in the ICU. But we did see a reduction of 1 day in the day spent delirious. And again, okay, 1 day might sound like who cares, but if we remember that 1 day of delirium increases your risk for mortality a year out of the ICU, I'm pretty happy with that result. In terms of 28-day mortality, ICU mortality in our study decreased. We actually nearly halved our ICU mortality. It went from 16% to 9% after the bundle was implemented into everyday care. Not significant. However, we did see a statistically significant drop in our total hospital mortality. So that includes ICU and hospital days. Our total hospital mortality was reduced from 19 to 11%. So the next logical people ask was, okay, that's univariate analysis. What happens when you control for other things that are known to contribute to delirium? So if you control for patients' age, whether they're not on the ventilator, whether their severity of illness and things like that. Well, when we control for a lot of the important covariates, we found that use of the ABCDE bundle, the odds ratio for developing delirium anytime during their ICU stay was 0.55. So we nearly halved the odds of developing delirium during their ICU stay. We also found that an increased odds ratio. So we increased the odds that a patient would get out of bed anytime in the ICU stay. And again, controlling for those important variables. Some of the other outcomes that we looked at for this part of the study were ICU length of stay, coma, and residence, and we really didn't see any clinically or statistically significant decreases in those outcomes. The next logical question, and the reason most people don't do these interventions in the ABCDE bundle, is they think all their patients are going to fall out of bed, crack their heads, and pull out their tubes. Well, we did not find any of that, luckily, in terms of implementation of the ABCDE bundle. In fact, in the post-implementation phase, we found less self-extubation rates, so people were actually less likely to pull their endotracheal tubes out. And another interesting thing that we found, and it's pretty consistent with several studies that are coming out, that those patients that did pull out their breathing tubes, not many of them need to have that breathing tube put back in. So the number of patients that self-extubated, pulled out their tube, that required going back on the ventilator was very, very low, which indicates to me, there is an urgent need for us to do frequent assessments of whether these patients are should be off the ventilator. They're kind of telling us, hey, I'm ready, get me off this thing, and do it themselves. Probably a good thing in the end for those patients, some of those patients. Also, post-ABCDE bundle implementation, so after the patients were treated with this ABCDE bundle, even though not treated nearly at 100% time that we wanted them to, we saw decreases in reintubation rates, the placement of tracheostomies, and the use of head CTs or MRIs for change in mental status. Now, one of the things, I just kicked myself, I sent all my slides to Heather 3 times today to do updates, and one of the things that I noticed, we spent, clearly we're almost done with our presentation, and the majority of it went to quantitative statistical outcomes. Well, I guess that just kind of shows my quantitative lean. However, the other aims of our study were really kind of even more mixed methods. We did a number of formal analysis of the barriers and facilitators of adopting this bundle into everyday practice. For example, we did a formal evaluation of our teaching effectiveness, or our learning that occurred from that interprofessional educational module. We did 3 online surveys where we followed them in the pre-implementation phase, 4 months out and 8 months out after the bundle was implemented into everyday care, to hear from the providers not only what they think about the ABCDE, their use of the ABCDE, but also really followed the pattern of teamwork and this, a safety culture and the teamwork culture and the communication culture through these surveys. And we had a number of interprofessional focus groups. So we really have a lot of information on these barriers and facilitators. The biggest problem in summarizing, and again, I can give probably a 2 or 3 hour lecture on all the barriers and the facilitators paper challenges that we had, and we are in the middle of writing that paper right now to share with all of you so that you don't have to learn from our rather unfortunate experiences at time. Really the biggest factor that I feel affected implementation was interdisciplinary communication. One of the qualitative researchers, one of the leading qualitative researchers in the country, attended some of these focus groups and was astounded by how the amount of communication that actually occurs in the ICU. She just assumed the patient was critically ill. The doctors would be there at the patient's bedside. I don't know how one doctor would be with 12 patients, but her assumption was that the doctors would be at the patient's bedside maybe half of the day, and the nurse would be at their bedside half of the day. They'd be talking and communicating regularly. Everybody would know what everybody else was thinking. So when she, conducted some of these focus groups, she was really surprised with the pretty dire straits in terms of communication that was occurring with the interprofessional team. So that communication really, before you do anything else, kind of has to be addressed before you would implement this bundle. In fact, our institution recognized that midway through the study that really they had to focus on getting interprofessional rounds, interprofessional ICU daily rounds into practice much more consistently. So they put a lot of their efforts as an institution in improving that process and then going back to revisit the ABCDE, because without those rounds, the other stuff is just so much more challenging to implement. The other concerns were, you could probably think of pragmatically most of them, resource allocation. Everyone feeling like their workload is really so pressed right now that they couldn't do an additional one thing in terms of their day. Nurses in particular worried about having enough physical therapists or enough resources to get these mechanically ventilated patients up out of bed. Respiratory therapists had issues in terms of being accountable for a number of different units and not feeling like they had a home base and things like that. Also the accountability. We found one of the challenges was if you're going to implement this into everyday care, how is the institution itself going to monitor compliance with the bundle? So who is the person that's going to hold the physicians accountable if they are DCing the ABCDE bundle every day they come in? Not that only happened once, and ironically it happened when the person that ordered it was actually one of our research team members. But who would hold the physicians accountable for maybe not extubating a patient for whatever reason, or for the nurse not shutting off the drip, and more importantly, how are you going to follow the outcomes of your patients? My experience to date has been that a lot of institutions don't have that monitoring capability. So the accountability and the ability to monitor the process and the outcomes. Documentation strategy, any nurse, probably any specialty in any area of the hospital will know that we're just drowning in terms of documentation. And one of the most common things that we heard from all of these groups was we would do it if we didn't have to document it. It takes more time to document than do it, and things like that. And also getting through this interprofessional practice policy, we had to go through 3 separate committees, because it's not like the good old days when nursing had nursing policies and procedures and that just applied for nursing, and respiratory therapy had their policy and procedure. This was truly an interprofessional intervention, so it affected a number of different specialties, and then henceforth had to go through numerous policy and policy revisions to get into place. So in terms of next steps, we've been extraordinarily effective in terms of communicating our findings. In addition to having a manuscript accepted to critical care nurse that described the bundle and started offering how this could be implemented through other ICUs. We are in the process. We've sent out our manuscript for review on the outcomes, and we're almost at ready to send out the next paper about the challenges. But really going through across the country, sharing our experiences and our stories and the ABCDE bundle with a number of different institutions. We also, interestingly, had so much excitement generated through this bundle. We have a bunch of secondary analyses that are occurring. And interestingly enough, even though this was really a nurse, at least co-led investigation, a lot of the secondary analyses are coming from other professions. So, for example, pharmacists are doing some of the cost analysis things. We have a medical student who's going through an MPH program who's doing several analyses with the data that we're having. So interesting in how much excitement it has generated among the different specialties. One of the things I'm most proud of is we are very, very close to almost finalizing our ICU, a website that we're developing. And this website was developed with funds from our study. It was a dissemination and implementation grant, so we wanted to extend that dissemination in unique ways. What we did is we bought the domain www.icusurvivors.com, and I am working closely not only with our research team, but some patients and their families who have gone through the devastating experience of delirium and are living with the devastating effects of the long-term consequences of it. So with it's really the patients and their families and their loved ones that are helping with this project. What we envision this website to be is a place for these people who have, lived an ICU stay, discharged home, should be happy they're alive, should be happy that they were near death and we saved them, and are struggling with why aren't I? Why am I having such severe depression? Why am I having such problems with my memory? A place someone can go to find out that they're not alone, that there's hundreds of thousands of people who've had the same experience, that they're not crazy, that there is hope, that there are interventions that they can do, and also for patients and their families to share what worked for them. Clearly, we're not, with funding the way it is these days, we are not going to be able to test all of the interventions we would like to test in terms of what would help these people prevent these long-term outcomes. And the funding probably wouldn't be out there to do like some of the more non-pharmacological interventions. But to share things, like I've heard people say, that the touch of their son or, their son standing next to them massaging their feet. So massage, music, art, journaling post-ICU, what things help them recover. So that's almost up and running, and probably within the next month. Paulie and I are going to Boston next month to introduce it to some of the artists up there. One of the artists that I'm working with is a survivor of the intensive care unit, Nancy Andrews, and she's been, so important for this the website in particular. Our next plan is to do a multi-center study. Not sure quite which way we're going to go yet with that, but really because of all the issues with nursing workload and cost and satisfaction and all of this relating back to all the individual professions. Probably something with that, and also if we do the multi-center trial, looking at using a different design, so something like a cluster step wedge design. And my desire, and Bill, I think, I'll let Bill speak to this, but we really need to know what happens to the patients that were treated with the ABCDE bundle long term. It's great, we have all these great things happening to them in the hospital, but if they're going to go home and have a life that's not worth living to them, really it's not for good, in my opinion. So follow-up studies of the long-term impact of this bundle. And that's our presentation. I've always found the most exciting parts of these presentations comes from questions from the audience. Bill, do you have anything that you'd like to add?
Really, I think you did a wonderful job of covering the major findings, which are up on the screen again. From my perspective, what makes me most excited about this is the idea that could reduce the rate of delirium, because for my people, being a geriatric psychiatrist, the thing that happens to them in the course of an ICU when they get delirious is that they either develop dementia or their dementia takes a step down. And it's going to be such a huge problem for us in the future that seeing something that's a common sense intervention that can reduce that problem is just fabulous. So I'll stop there and see if questions are out there in the audience.
So,
Great, thank you so much.
This is Allison, and if I might, I'd like to jump in with an early question. So thank you both for the excellent presentation. That was really interesting. And I was intrigued by all of the comments about some of the challenges that you experienced in actually getting the implementation to happen. So I wonder if you could speak a little bit more about how you would characterize the reaction of staff to the level of coordination required for this kind of intervention, and in particular whether or not it changed dramatically pre versus post intervention, and whether you could share some key observations or lessons learned there.
Bill, do you want to start, or do you want me to?
Oh, go ahead, Michelle.
Okay, so I think there's a number of questions inside that question, and they're all extraordinarily important. I think our experience was a little unique. So this whole translational dissemination and implementation research has opened much broader worldview of myself. One of the things that I think might have impeded really aggressive adoption of the bundle itself was the fact that we were doing a translational research project. So I think a lot of people at the institution struggled with the fact, well, is this just a research thing that's going to go away in a couple months? Even though we told them over and over again, we're adopting this as standard of care, and all this is going to be standard of care. I think maybe some of it might be that this crazy lady from New Jersey is here for the next year and will go away, and that it's not really going to be what we're held to that standard. So some of that might have been there. I think another challenge that occurred is. One of the issues that we face is, did we do it the right way? So we went in, because the institution told us that they, did awakening trials, they did breathing trials, and, they're piloting this thing. Really, it seemed like the only thing that was missing was the delirium part of it. We chose to go and develop the ABCD policy as one policy that had all of those components together, and that we would do all the teaching and all of the education around the bundle itself. Not sure that that's the best way to go. We chose to go that way because we were told that they were doing the awakening and the breathing trials. Maybe clearly, all of the quality improvement literature tells us, you take what you're doing, maximize how good, maximize how well you're doing that intervention, and then move on to the next. So that might be possibly more effective. I don't think so. I still think, keeping it and teaching it as one bundle is probably the way to go. And I say that because clearly you're not going to be able to do the E, so the early mobilization, if the patients are still on continuously infused sedatives. You're not going to be, so I think, although I think optimization of the things that you're good at and going at one step at a time might be important, I think the emphasis still has to be in place in terms of overall how all of those interventions affect each other. The institution, in terms of what they're doing now, they are deeply committed to continuing with this since we kind of formally, left the environment. They're deeply committed to that. They're doing a number of things to optimize implementation. They have, the pharmacists looking at, implementing the new pain, agitation, and delirium guidelines, a number of people doing stuff with early mobilization, but they strongly felt that they had to get that rounding thing done first. And get that daily ICU rounding down, and using that checklist, which incorporates the components of the ABCDE bundle, getting that into everyday ICU rounds before they can take a step forward.
Great, thank you. One follow-up to that is, whether or not you have any ideas for additional tools, so beyond the checklist, and particularly as you noted that there were some real challenges around just documentation, whether there are any additional tools or resources that might help further facilitate this collaborative work of interdisciplinary teams implementing the bundle.
Yeah, so I always offer that the Vanderbilt website, icdelirium.org, has a ton of information available to people that are interested in delirium and cognitive impairment. One of the things that we faced when we first started this was, although the theory kind of behind the ABCDE bundle was laid out, there wasn't really any how-to kind of thing that says what are the safety screens, what are the safety screens, what are the pass criteria and things like that. So now we at least have that kind of, and that came through the critical care nurse article. So what we did is we described what we were doing here at the Med Center so that people can take it back to their institution and tweak it to what they think works and what doesn't work. While you can't remove any of the components of the bundle, there is opportunity to tweak to what the institutions need to kind of personalize what you're doing in your intensive care units in terms of the safety screen guidelines and the pass-fail guidelines and things like that. Also, Brenda Pun was, the lead on the ABCDE Pearl thing from the American Association of Critical Care Nurses. That is available on their website, which has a lot, in addition to the stuff on the bundle itself, has a lot of great quality improvement kind of initiatives going on. But I can't overemphasize, if you're planning to devote 40 hours to education, triple it. Because the myths and misconceptions related to sedation and delirium are so deeply woven into our souls as critical care providers, you cannot imagine how hard it is for people to adopt these practices. We were taught that we were doing the right thing to our patients by sedating them while they're in the ICU. That was the right, the humane, the calm, the compassionate thing. I remember being an ICU nurse saying to my colleagues, if I'm awake and I'm in the ICU and you don't sedate me, I'm going to come back and haunt you. I mean, these things we've been taught all of our lives are the right things to do about the patients. And now we know that not so much, that we may actually be harming our patients with some of the things that we've just considered the right thing to do. And it's so hard to get those deeply ingrained beliefs out of people's daily practices. So if you're planning, like I said, 30 hours, triple it, quadruple it, whatever you think. And the interprofessional nature, it can't be done without doing that education for everybody involved.
Great, thank you. It's a great example of the learning healthcare system in action, right?
Exactly.
I'm wondering, in addition to the outcome measures presented, were you able to do any qualitative assessments? I know you mentioned it was mixed methods, but of the patient and family perceptions of or reactions to the intervention. So it sounds like you're continuing that to some extent with your website work, or that's a focus for your website work, but I'm wondering if there was sort of a formal effort to assess their reaction to the intervention.
That's pretty funny. So, yes, there was. We actually applied for a INQRI grant, the same team that did this team. Unfortunately, we didn't get it. But what we proposed to do, because it was just the wrong time for that proposal, what we proposed to do in that grant was to take the patient and their family's experiences as the lead for what they think of this bundle. Again, that's what's important. If we found that, their experience was negative in terms of whatever, it's important for the providers to know that. So that clearly will be, in any, our next study will definitely have as one of the research team members and a family member or patient in that area, because their voices are so important. But I can tell you, just with the publicity that came through working with the Robert Wood Johnson grant, I can't tell you how many people that were discharged from the ICU, again, that are living, have come and have reached out to me that are at the tipping point in their life. They are struggling so bad with the PTSD and the depression and thinking that they're crazy and thinking that they were isolated in this experience. It has moved my soul. These people are crying out for help, and so one of our steps is, one of the steps is this, website that we're developing that will hopefully be, a stepping point for at least to get them connected with each other, so that they know they're not crazy. But moving experience, dramatic moving experience when you talk to the patients and their families, and clearly we'll need to be involved in research as it goes forward.
Well, it sounds like it was very powerful, so thank you for your tremendous work. I wanted to pause and see whether there were any other questions that had come in.
We have nothing on the phone lines, but as a reminder, that is *1 if you'd like to queue up for a question or comment.
Okay, and actually I see one on the chat function, so I'll go ahead and ask that, and then if somebody comes in on the line, you can cut me off. But the question is regarding plans for the multi-center trial. Could you talk a bit about how you're going about identifying participants in order to test the generalizability of some of the initial findings, particularly with respect to setting and patient population?
I'm sorry, I don't see the question, and I lost the second half of that, what you were asking. How we're going to identify participants, do they mean institutional participants or?
Yes, institutional participants.
Well, that's a great point. I can tell you that there's been a tremendous amount of interest generated in the ABCDE bundle. And again, one of the challenging issues is this is best care. This is evidence-based standard of care. It would not be fair, it would not be effective, and it would not be, I'm sure there's a proper term, Bill, ethical, maybe it's ethical, to do a prospective randomized control trial. Give some of the, some of the patients standard of care, and other patients will get the ABCDE bundle. I don't think you could do a prospective randomized control trial because of that issue. Again, enrolling the participants, we would have to probably use some other kind of design that's more accepted for the very quantitatively randomized control trial focused people, again, just to move the science forward to prove that it works. And unfortunately, an effort like that's going to cost a lot of money, to do it the right way. So in terms of, identifying participants, if they mean at the patient level, I don't think you could do like a randomized control trial. If they mean at the institutional level, I think that there are so many institutions that aren't doing these things, they'd be pretty easy to identify, if that's what the question is.
Right, thank you. I'm mindful of time, but I wanted to see if either of you had additional points that you particularly wanted to elaborate on coming out of the Q&A, or Heather or Lori, if there's others who wanted to jump in at this juncture.
So this is Mary Naylor, and I just wanted to congratulate you and your unbelievable team, Michelle and Bill, and your unbelievable team for this extraordinarily important work. Over the years, I've learned that what translation often requires of even the most rigorous evidence is a committed and passionate set of champions, and I certainly, even in the last hour, you've communicated that beautifully, how extraordinarily important the human experience has been in moving and advancing your work and commitment to it. So I really want to congratulate your entire team. We are so proud of what you have been able to accomplish and the movement that you're a major part of. And so I don't want to say that on behalf of RWJ and the INQRI program.
Thank you, Mary. We do have the best team in the entire world. I'll proudly say.
Catherine, do we have any other questions submitted on the queue?
No, ma'am, no questions on the phone lines.
Great. Well, then I'm going to thank all of you so much for joining us today. It's been a wonderful session, and thank especially Michelle and Bill, and of course Allison and Lori and Mary for being with us today, and thank you to all of you for participating as well.